Hi, good evening to all distinguished delegates and our eminent speaker. I, Sharan Gupta from Zydus Medica, honored to welcome all of you to this scientific digital program called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Giving you all a small brief about ClearTalk. ClearTalk is one more initiative of Zydus, which encompasses one more facet of Unite Against Dyslipidemia. As you know, in India, 1.24 crore population are having uncontrolled LDLC, which increases cardiovascular risk. And for that, recent development in the field of management of dyslipidemia brings you bempedoic acid as an add-on choice for LDLC management. Hence, this session of Clear Talk is focused on one more development that pharma and medical fraternity are witnessing, that is late-breaking clear outcome trial presented in ACC 2023. The program is based on our objective of increasing awareness about the usage of bempedoic acid for all practicing physicians and general practitioners. It is basically to upgrade the knowledge on the late breaking CVOT trial and management of LDLC and dyslipidemia. Well, to take this program ahead, we have our eminent speaker, Dr. Arindam Naskar. Just to give you all a brief about Dr. Arindam, he is assistant professor in WBMES. He is in charge of Department of Endocrine, NMDSTM, Kolkata. He has MRCP certificate in Advanced Diabetes Management and also Harvard Medical School regional faculty. Uh, he will be taking a session on bempedoic acid through the lenses of clear outcome trial. Good to have you here, sir. We welcome you from Zydus Medica. Before we start, we just wanted to update all the participants that if you have any questions or queries, you can anytime post them into the comment section. Now, with further ado, I would hand over the session to Dr. Arindam. Over to you, sir. Thank you so much for being our eminent speaker, sir.
Yeah, thank you, Mr. Sarang, for your nice introduction, and thank you to Zydus for giving me the opportunity to speak on this topic, Clear Talk. So let's start. Am I audible?
Yes, sir. You are clearly audible, sir.
Okay. Yeah. So bempedoic acid through the lenses of clear outcomes trial. Now, why LDL lowering LDL cholesterol is very much important, because only 1 millimeter millimole per liter, or 38.7 milligram per day reduction in LDL cholesterol that reduces 23% relative risk reduction of related major cardiovascular events. And all these trials, if you can see in the slide, that there are different trials done on anti-lipidemic drugs, that is 25 trials on statin, 4 trials on diet, 3 trials on niacin, 9 trials on fibrates, CETP 3 trials, ETP 1 trial, PCSK9. So all these trials, they have been clubbed in a single slide, and they show that how reducing LDL cholesterol is very much important in reducing the risk of cardiovascular events. And I already mentioned each 1 millimole per liter reduction of LDL gives more cardiovascular event reduction according to number of years in trials and comorbid conditions as well. In 1 year trial, if the patient is in 1 year therapy, so there is 11% reduction, or 3 to 5 year 33%, and it's more than 6 year is 36% risk reduction. And risk of non-fatal MI, coronary heart disease, death, and stroke percentage over 5 years. It's like LDL cholesterol. If you can see the slide from 4.2, 3.4, how the lowering of LDL cholesterol is helping the CVD and diabetic, CVD and metabolic syndrome with impaired fasting glucose, and CVD without diabetes. So how the risk reduction is happening with the different level of LDL cholesterol. So if you reduce your LDL cholesterol more and more, there is more chance of reducing the cardiovascular events. Now, management of dyslipidemia is high on priority, and statins are first-line therapy, you all know. But there are few concerns. Like concern 1, do all statin users achieve LDL cholesterol goals as per guideline recommendations? And concern 2 is how to achieve LDL cholesterol target after maximally tolerated dose of statins? Now let's see. So do all statins first concern achieve LDL goals as per guideline recommendations? So what is the target LDL level should be? This is the Lipid Association of India 2020 guidelines, the CVD risk stratification, how they have stratified the CVD risk factors. Like the risk factors are the major risk factors: male age more than 45 years, female age more than 55 years, family history of premature atherosclerotic cardiovascular disease, current cigarette smoking or tobacco use, hypertension, and low HDL cholesterol. So these are the major atherosclerotic cardiovascular disease risk factors. Next is the moderate risk factors. That is non-conventional risk factors. If the coronary calcium score is 100 to 299, increased carotid interval medial thickness, lipoprotein level 20 to 49, impaired fasting glucose, increased waist circumference. Means in Indian population, if the waist circumference of a male is more than 90 centimeter and the female is more than 80 centimeter, that's called increased waist circumference. And ApoB more than 110 and high sensitive CRP more than 2. So these are the moderate risk conventional risk factors, and other high risk factors are diabetes with 0 or 1 other major atherosclerotic cardiovascular risk factors and no evidence of target organ damage. And I already mentioned the major atherosclerotic cardiovascular risk factors, which is you can see in the extreme left hand of the slide, upper left. Next is CKD stage 3 or 4, familial hypercholesterolemia, extreme of a single risk factor, coronary calcium score more than 300, non-stenotic carotid plaque and lipoprotein more than 50. So these are the different risk factors associated with development of cardiovascular disease. And how they are stratified: risk group. Low risk group is 0 to 1 major ASCVD risk factor and lifetime CVD is less than 30%. Moderate risk is lifetime CVD is more than 30%. 2 or major ASCVD risk factors. Low risk group with more than equal to 1 moderate risk factors, non-conventional risk factor. High risk, more than 3 major ASCVD risk factors, like if age is more than 45, family history of premature ASCVD, cigarette smoking, or high blood pressure. So any 3. And 2 major ASCVD risk factors with more than 1 moderate risk factor, conventional, non-conventional risk factors, like the calcium score high, more than 100 to 299, increased carotid interval medial thickness, lipoprotein 20 to 49. So these are the high risk group. And next is a very high risk group. The yellow mark you can see in the slide, pre-existing, those patients who are already having pre-existing atherosclerotic cardiovascular disease, diabetics with more than 2 other major ASCVD. It is important because of diabetic patients, if a male patient, if his age is more than 45, so 1 major ASCVD risk factor, and if the patient is smoker or patient having hypertension, so 2 risk factor. That means that diabetic patients with other 2 major ASCVD risk factors like age more than 45 of male or 55 of female, either tobacco use or high blood pressure, he falls in very high risk group. Or familial homozygous hypercholesterolemia. And who are in the extreme risk group, they are divided in 2 groups, category 1 and category B. Category A is coronary disease with more than equal to 1 feature of high risk group. So high risk group is like more than 3 major ASCVD, 2 major ASCVD risk with more than 1 moderate. So they are categorized as category A. And category B is coronary disease. Patient have suffered from coronary disease or having coronary disease with more than 1 features of very high risk group or recurrent acute coronary syndrome within 1 year, despite LDL cholesterol less than 50. So despite the patient's LDL cholesterol less than 50, patient is still having recurrent acute coronary syndrome within 1 year, they falls under category B or extreme high risk. Why they have stratified the risk groups? Because according to the risk group level, they have set the target LDL level. Like the treatment goals. So extreme risk group, category 1, the LDL cholesterol should be less than 50. And extreme risk group, category B, the LDL cholesterol should be less than 30. So extreme risk group category A and category B. Just going to the previous slide again. So extreme risk category A, patients having coronary disease with more than 1 or equal to 1 feature of high risk group. Category B is CAD with more than 1 features of very high risk group or recurrent acute coronary syndrome despite LDL less than 50. So in those populations, the target should be LDL less than 30. And very high risk group less than 50, high risk less than 70, and moderate to low risk is less than 100. So if a diabetic patient with hypertension, suppose diabetic patient with a major ASC risk factor like hypertension or age more than 45, then it falls under very high risk group. So you need to reduce the cholesterol level, LDL cholesterol level less than 50. Now, comparison of LDL cholesterol target, European Society of Cardiology 2016 versus ESC 2019 guidelines. So in 2016, they categorized low risk group. The LDL cholesterol level target was less than 115, which is same in 2019 ESC guidelines. But in moderate risk group of patients, previously it used to be less than 115. Now it's come down to less than 100. In high risk, ESC 2016, it was less than 100. Now, according to recent ESC guideline, it's less than 70. And the very high risk group, now the recent ESC 2019 LDL is less than 55, its target, which previously it was less than 70. So ESC has already modified their LDL cholesterol level from 2016 to 2019. So high risk should be less than 70, very high risk should be less than 55. So as cardiovascular risk increases, need to reduce more LDL cholesterol. Now, based on revised ESC 2019 guideline, how many patients do have controlled LDL cholesterol? So how many patients are really controlled, have really controlled LDL cholesterol according to ESC 2019 guideline? Let's see. So this is a study, the Da Vinci study. The objective of the study to evaluate impact of ESC 2019 dyslipidemia management guideline on LDL cholesterol goal achievement. And this is a study, that is European Union wide cross-sectional observational study of lipid modifying therapy using secondary and primary care. 18 countries of Europe were involved. Almost 6,000 patients were involved. Primary prevention was 3,000 and secondary prevention was 2,888. And what they showed that overall, among more than 4,000 patients, all patients, the proportion of patients receiving the target LDL level, receiving the lipid lowering therapy, was the 27%, 27.6% of eligible patients are receiving high intensity statin. So overall, all patients, amongst all patients, only 27.6% were eligible patients for receiving high statin therapy. And 30% patients achieve lipid goals with high intensity statin. 30% of patients, they only achieve lipid goals with high intensity statin. If you look, there is a comparison data in 2016 and 2019. If you look carefully, the red line is 53% in 2016. It was 53%. That 53% patients achieve lipid goals with high intensity statin. But in 2019, they showed that 30% patients only achieve lipid goals with high intensity statin. So it's hugely deviated from the original LDL cholesterol target level. So only 30% patients. And what about the statin usage in very high risk patients? So very high risk group, amongst 2,000 patients were in very high risk group, and amongst them only 37%, 37.5% of eligible patients are receiving high intensity statins. And 22%, if you can see the red line, the red line is they have been arrowed that high intensity statin monotherapy. So 22% patients achieve lipid goal with high intensity statins. So amongst very high risk group patients where you have to reduce the LDL cholesterol level at least less than 55, only 22% achieve lipid goal with high intensity statin. So only single statin therapy is not sufficient to reach the target value of less than 55 in very high risk group patients. So that's a quite important observation of Da Vinci study. Now the next concern, how to achieve LDL cholesterol targets after maximum tolerated dose of statins. So despite the patient has got the high intensity statin therapy, the target LDL level is not achieving. So then what to do? Next, I'm coming to the, I'll come to the answer in my next few slides. Now, high intensity statin, it has low adherence which leads to higher MACE events. If you can see the graph that adherence to high intensity statin is like a very important issue. Observational study of 23,240 post-ACS patients were prescribed high-intensity statin after index event. Amongst them, 66.4% patients of all patients presenting with ACS did not take high intensity after discharge. So 2/3 of patients, they did not take high intensity statin after discharge. And more than 50% of patients had drug interruption at the end of therapy within the first month after the index event. So after the acute coronary syndrome, they stopped 50%, more than 50% of patients, they stopped high intensity statin therapy. And non-adherence to high intensity statin had a strong association with higher mortality by 16%. So as because they stop statin therapy after a few months or after a few days, there is a high mortality rate. Now coming to the today's discussion, the molecule of bempedoic acid. What is bempedoic acid? First in class LDL lowering drug, that is ATP adenosine triphosphate citrate lyase inhibitor, and is approved in countries like USA, European, Indian, and India. It is approved in 2020 in US and European Union, and the approved indications are to reduce uncontrolled LDL cholesterol with maximum tolerated statin dose, mixed dyslipidemia, familial hypercholesterolemia, high risk of ASCVD patient, and statin intolerance or whom statin is contraindicated. So first, bempedoic acid was concepted used in those patients who are statin intolerant, having statin related adverse effects of myalgia, muscle, other like muscle complaint. So in those groups, bempedoic acid, the indication. Then it was also used in uncontrolled LDL cholesterol with maximum tolerated statin dose, and dose is 180 milligram orally with or without food. Now, how does it work? So a novel mechanism of action, it inhibits ATP citrate lyase enzyme. If you can see the slide, that bempedoic acid, when it's in presence of very long chain acyl coenzyme synthetase enzyme, it converts to this its active drug bempedoyl coenzyme A, and it inhibits the ATP citrate lyase enzyme, and it blocks conversion of citrate, because citrate forms it forms acetyl coenzyme A. It blocks that enzyme, and citrate is not converted to acetyl coenzyme A. And it's actually it works in this activation happens in liver, and it is not activated in skeletal muscle, as long chain acyl CoA synthetase is not expressed in muscles. So it does not have any muscular side effects. So only it acts through liver, and it inhibits it's upward. If you can see that HMG CoA reductase inhibitor statins and the ATP citrate lyase inhibitor bempedoic acid, it acts two steps above the HMG CoA reductase inhibitor. Same pathway, but it 2 stage upwards from the HMG CoA reductase inhibitor, and it decreases cholesterol synthesis by increased regulation of LDL cholesterol level and decrease LDL cholesterol in the blood. And also bempedoyl coenzyme, the active drug, also weakly inhibit the organic anion transporter 2, and there may be raised uric acid level and slightly raised creatinine level. So there may be associated hyperuricemia because of weak inhibition of OAT2. And in skeletal muscle, it's not activated because of ACVS-VR is not expressed in muscles. So the mechanism is simple. It's upstream to HMG CoA reductase, 2 steps upstreams. Now, management of patient receiving bempedoic acid therapy, half-life is 21 hours. Elimination is 70% excretion of total doses through kidney, 5% excretion through feces, and less than 2% excretion of unchanged drug through kidney. Renal impairment, it's actually you should not use if the EGFR bempedoic acid, the EGFR is less than 30, because there is no strong data available till now. But if the EGFR is more than 30, you can safely use bempedoic acid. And hepatic impairment, no dose adjustment needed, but there is no enough data available in patients with severe hepatic impairment like Child-Pugh C. And you have to monitor certain things, like all patients you have to assess serum uric acid when clinically indicated. As I already mentioned, that the active form of bempedoic acid, the bempedoyl coenzyme A, they are a weak inhibitor of organic anion transporter, and there may be increased uric acid level. And if the patient having prior history of gout, so increased vigilance for hyperuricemia and gout. And patients more than 60 years of age taking steroids or fluoroquinolones with renal failure and a history of tendon rupture. Why steroids and fluoroquinolones? Because if you co-prescribe bempedoic acid with steroids or fluoroquinolones, there is more chance of tendon rupture. And discontinue. Patients, when you should discontinue bempedoic acid? Patients more than 60 years of age taking steroids or fluoroquinolones with renal failure and a history of tendon rupture. Discontinue if tendon rupture occurs. So if there is tendon rupture, then you have to discontinue bempedoic acid. And consider discontinuing if joint pain, swelling, or joint inflammation occurs in any patient. Next is taking simvastatin. So co-prescription of simvastatin dose more than 20 milligram or pravastatin more than 40 milligram you should avoid. Or you consider lowering dose of switching statin. But you can safely prescribe it with atorvastatin or rosuvastatin. And in pregnant and lactating women, you should not use bempedoic acid. So these are the concerns of bempedoic acid therapy. Now this is the overview of bempedoic acid phase 3 program for trials like Clear Harmony, Clear Wisdom, Clear Serenity, and Clear Tranquility. Clear Harmony and Clear Wisdom, bempedoic acid was co-prescribed with maximally tolerated statin background therapy. So patient was already on maximally tolerated high intensity statin therapy. Amongst them, bempedoic acid was tried in atherosclerotic cardiovascular disease or familial hypercholesterolemia. They are already on statins. And Clear Serenity and Clear Tranquility, those were studies where bempedoic acid was used where there are no statin or very low statin background therapy, where statin intolerance or patient was afraid of using statin. In those groups, Clear Serenity and Clear Tranquility studied. So two groups, Clear Harmony and Clear Wisdom, where maximally tolerated statin therapy was in the background, where bempedoic acid was used, and 52 weeks they followed up. And Clear Serenity, Clear Tranquility, background of patient was non-tolerant to statin or very low dose statin was used. And what they showed, in left hand side, the blue lines are persistent hypercholesteremia statin. Clear Harmony, Clear Wisdom, there is a clear lowering of LDL cholesterol with co-prescription of background high dose statin therapy. So in Clear Harmony, after 12 weeks of therapy, 16.5 milligram per day LDL cholesterol reduction, and Clear Wisdom 15.5 along with high dose statin therapy. And patients who are not on statin therapy, statin intolerant or very low dose statin therapy, bempedoic acid significantly reduced LDL cholesterol level. In Clear Tranquility is 23.5 and in Clear Serenity is 23.6. So bempedoic acid reduced LDL cholesterol when they used with high intensity statin therapy as well as without statin therapy or who are statin intolerant. Now, how to be effective with lipid lowering therapy in very high risk patients? ASCVD patients check baseline LDL cholesterol level. ASCVD like acute coronary syndrome, stroke, or peripheral disease. So high intensity statin is reducing only 50% of LDL cholesterol level. High intensity cholesterol with ezetimibe therapy 65%. High intensity statin with bempedoic acid also the same level of LDL cholesterol or 65 to 70%. And when the triple therapy like the fixed dose combination of bempedoic acid and ezetimibe and high intensity statin, 75% reduction of LDL cholesterol. So if you use the three drugs like high intensity statin, bempedoic acid, ezetimibe, so you can achieve up to 75% of LDL cholesterol level. And high intensity statin, ezetimibe, and PCSK9 is 85%. But you all know that PCSK9 is very costly molecule. We don't use it very day-to-day routine practice. So apart from that, so if you use the triple therapy when the LDL cholesterol is not achieving with the high intensity statin, then it's very much effective. And also familial hypercholesterolemia, 65% in high intensity statin with with ezetimibe and high intensity statin with the bempedoic acid 65 to 70%, and statin, bempedoic acid, ezetimibe 75%, the triple therapy. And those populations were complete statin intolerance. Bempedoic acid with ezetimibe combination, they reduce LDL cholesterol by 40%. It's not a quite less number, 40% without statin therapy. PCSK9 only 50 to 60%, ezetimibe with PCSK9 70%, and bempedoic acid, ezetimibe with PCSK9 80 to 85%. So these are the different groups where bempedoic acid work, like familial hypercholesterolemia, ASCVD, complete statin intolerance. So these are the LDL lowering capacity of bempedoic acid. Now coming to the latest CLEAR outcomes trial. So previous trial was like how bempedoic acid is reducing LDL cholesterol, how much is effective, but there was no definite cardiovascular safety trial was there, or how does it reduce the cardiovascular events. So now comes the CLEAR outcomes trial. It was published in New England Journal of Medicine very recently in in ACC 2023. It was published, and the journal was published in NEGM and also published in ACC article. So cholesterol lowering via bempedoic acid and ACL inhibiting regimen, that is CLEAR outcomes trial. The background was statin intolerance occurred in 15% of treated patients, and that prevent patients from achieving LDL cholesterol levels and cardiovascular benefits. Bempedoic acid is an ATP cyclase lyase inhibitor. Bempedoic acid approved for lowering LDL cholesterol, but CV outcomes not assessed. So now CLEAR outcome trials, they came with the CV outcomes of bempedoic acid. So global CV outcome study of bempedoic acid in statin intolerant patients with elevated LDL cholesterol. So those patients who are statin intolerant, they have been prescribed bempedoic acid, and CVOT trial has been conducted. Primary and secondary prevention, patients with elevated LDL cholesterol and statin intolerance, patients are screened and they've been used bempedoic acid 180 milligram per day. 7,000 patients when they got bempedoic acid 180 milligram per day, and 7,000 was placebo. And the primary endpoint was to look for MACE, 4-point MACE, major adverse cardiovascular event like CV death, non-fatal MI, non-fatal stroke, or coronary revascularization. And they have been studied for 2 years. Now, primary and secondary endpoints, I already mentioned that primary endpoint was 4-component MACE, non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death, CV death. And the hierarchical testing of key secondary endpoints is to look for 3-component MACE, MI, stroke, or CV death, fatal and non-fatal MI, coronary revascularization, fatal and non-fatal stroke, CV death, and all-cause mortality. And the CLEAR outcomes, the demographic data, mean age of 65 in both arms, and the baseline LDL cholesterol was mean LDL cholesterol was 139 in both arms. GFR more than 90, 60 to 90, 30 to 60, so they did not take less than 30 eGFR group in the study. CV risk category, primary prevention and secondary prevention, CAT, PAT, or peripheral disease and cerebral vascular disease, they have been recruited. Diabetic patients were almost 45 patients in bempedoic acid and 46.3% placebo arm, and 22.9% patients in bempedoic acid arm was used statin, and 22% were in placebo arm. 11.5% patients were on background ezetimibe therapy. So these are the demographic data of CLEAR outcomes trial. And what they showed that there was 13% relative risk reduction of 4-point MACE in compared to placebo. So bempedoic acid reduced the 4-point MACE in 13% population in compared to placebo. But 3-point MACE reduction was 15%, and fatal or non-fatal MI was significantly reduced by 23% when compared to placebo. And 19% patients, they reduced coronary revascularization. So they proved that bempedoic acid can reduce the 4-point, 3-point MACE as well as fatal, non-fatal MI and coronary revascularization. Now the effect of trial regimens on CV events. So among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-component MACE, 3-component MACE, MI, coronary revascularization. And also, they also reduce the high sensitive CRP, because high sensitive CRP, you all know that associated with inflammation, and that can increase the cardiovascular risk. So bempedoic acid in compared to placebo, there was significant reduction at the 6 month, that's 22.2%. After 1 year, 20.6%, and end of trial it was 19.4% when compared to placebo. So significantly reduction of high sensitive CRP, and 21.7% reduction of LDL cholesterol when compared to placebo. But bempedoic acid, there is no overall reduction of all-cause mortality and fatal or non-fatal stroke in compared to placebo. So the safety analysis, what are the safety analysis with that? Clear outcomes. Serious adverse events were 25.2, is almost similar to placebo arm. Adverse events were almost similar. Myalgia was less than placebo, almost similar. Only there is slightly increased risk of hyperuricemia when compared to placebo and gout. And also the change of baseline from baseline creatine level after 6 months, there was slightly increased renal impairment. And change from baseline uric acid level was more in compared to placebo. So there was concerns of hyperuricemia and slightly increase of creatinine. So they concluded that bempedoic acid becomes a fast ACL inhibitor and fast oral non-statin to demonstrate statistically significant reduction of 4 MACE events in patients who are high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. So now it's been stamped that bempedoic acid is a very much cardiovascular safe drug, and also it reduces the major adverse cardiovascular events. Now, bempedoic acid, an effective alternative for statin intolerant patients, are clear outcomes. Well tolerated. Bempedoic acid was well tolerated in a mixed population of primary as well as secondary prevention patients unable or unwilling to take statins. LDL and high sensitive CRP reduction was there. They reduced LDL by 21.7% and hsCRP by 22.2%. But there is slightly small increases in incidence of gout and cholelithiasis. The primary endpoint, 4-component MACE was reduced 13%, 3-component MACE 15%, MI 23%, and coronary revascularization by 19% at the end of trial. So effective approach as bempedoic acid as an effective approach to reduce major adverse cardiovascular events in statin intolerant patients. So thank you all for your patience hearing.
Thank you so much, sir, for this insightful and indeed very knowledgeable session. So we have some questions, sir. I'll ask you one by one, and I'll take you through the questions. The first question asked is, as per revised ESC 2019 guidelines, many patients have uncontrolled LDLC, but they don't have any complications. So should I increase the dose of statin or to add bempedoic acid or ezetimibe combination, sir?
No, actually, you have to follow the guidelines. You have to know the background history, so that the patient's age. I already mentioned, according to the Lipid Association of India guidelines. So age is important. If male more than 45, female more than 55 years, if the patient is smoker, having a history of premature cardiovascular death, so age less than 55 in male, less than 65 in female, you need to think of the background history. So even if the patient is still asymptomatic, if the LDL cholesterol is not at the target level according to the guideline, we need to reduce the level up to the target level. So that's important. When we get all like many patients in our diabetic OPD, so diabetic, they don't have any symptoms with LDL cholesterol level. So suppose 90 or 80, they have risk factor like the smoker, age is more than 40. I already mentioned the diabetic patients with 2 major adverse cardiovascular risk factor. You need to reduce the dose by less than 55. So that's important.
Yeah, thank you so much, sir. The next question is, I have many patients of type 2 diabetes mellitus and hypertension. So what LDL target should I keep for these patients?
Well, actually, diabetic patients with one major atherosclerotic risk factor, so the target should be at least less than 70. It's a high risk group. Okay. But if the patient having diabetic, only diabetic and having some atherosclerotic cardiovascular disease, then it comes under very high risk group patients. You need to reduce under 55 LDL cholesterol level. And also if the patient having diabetic patients with more than 2 or 3 risk factors, like diabetic patients, stage 3 CKD, or suppose patient is smoker, having coronary disease, already known CAD, then you need to reduce the dose LDL cholesterol less than 55, and extreme risk group of patients like recurrent acute coronary syndrome, CAT, less than 30s according to the guideline. So you need to think the background. You need to take care of all the factors like smoking, whether the patient is having, like already there are factors like patient having obesity because waist circumference is mentioned, because we don't routinely send apolipoprotein B or lipoprotein A in our practice, but that should be sent according to guideline because all are risk factors. So according to the patient scenario, if the patient having recurrent ACA, so they need to reduce the LDL cholesterol less than 30, because we don't know the lower limit. So less than 30 means how much is like 20, 25. You have to reduce at least up to 30. If there is extreme risk categorization, is category B.
Okay, thank you so much, sir. The next question is it appropriate to keep LDL-C below 40 mg per dl as per guideline recommendations? Can it lead to neurological complications?
Yeah, actually, there is a study, Omen study, done in more than 17,000 patients. They showed that if you keep LDL cholesterol very low, then there is a chance of hemorrhagic stroke. But there is no lower limit of LDL cholesterol. There is no sufficient data. Only one study, it's not significant. There's no sufficient data, and it's been shown that if you keep LDL, there are different studies been done, PROVITE trial, IMPROVITE trial. They showed that even if the LDL cholesterol is less than 30, there is no so much significant increase of hemorrhagic stroke. Like no sufficient data available. Like you cannot reduce the LDL cholesterol up to less than 30 or less than 40. So they have been safely reduce the LDL cholesterol level up to less than 30 and continue, but there is no increased evidence of hemorrhagic stroke or cataract.
Okay, thank you so much, sir. Sir, the next question.
Actually, just I want to answer the question. The physiology level, when a newborn baby is born, the LDL cholesterol level is 30. So 30 is a sufficient level to supply the nourishment of the. So it's a physiology. Okay. So you have to keep the LDL cholesterol as much as low as possible.
Okay, thank you, sir. The next question is, sir, if patient is having elevated LDL-C with moderate statin dose, then what should we do? Either to increase dose of statin or to add bempedoic acid?
Well, if the patient is on moderately intensity statin, I think we should the mechanism of action you have to, it is important because the bempedoic acid and statin works in the same pathway. So according to guideline, I would suggest to preferably you should select an agent that inhibits a different pathway. So moderate intensity statin, before going to bempedoic acid, I would suggest that that's according to guideline, you can go for ezetimibe because it acts on a different pathway. So statin and then the ezetimibe, still the LDL cholesterol is not controlling, then you can use bempedoic acid as the third agent.
Okay, thank you so much, sir. So just two more questions. What % of statin intolerance do you observe in your routine practice? Can bempedoic acid be drug of choice for those patients?
Yeah, definitely. Bempedoic acid is drug of choice for those patients because bempedoic acid was originated from the concept of statin intolerant patients, statin intolerant cases. They have been tried for those patient populations who are statin intolerant. So definitely that's a very good choice, but I don't see very much frequent statin intolerant cases in my practice. Yeah, I see, but it's not very much frequent.
Okay. Sir, last question, sir. What should be ideal patient profile for bempedoic acid plus ezetimibe combination along with statins?
Well, ideal patients is suppose patient is getting high intensity statin. Still, the LDL cholesterol is not up to the target level. Then we have used ezetimibe therapy. Still, the LDL cholesterol is not up to that level. Then you can use bempedoic acid. So triple therapy, I already showed in the slide that almost 75% reduction of LDL cholesterol from baseline. So that combination therapy, triple therapy, is very much effective.
Okay. Thank you so much, sir. Sir, do you like to give any closing remarks before?
Closing remarks is, actually, you need to closely, the important thing is that you need to closely monitor the uric acid level, because we have seen that lots of patients, as they have been suffering from metabolic syndrome, this diabetic hypertensive patients, many patients, they are already on gout therapy or hyperuricemic therapy. Suppose they are getting allopurinol or febuxostat. So if you use bempedoic acid and bempedoic acid statin combination, so you need to be a little bit more careful. You need to frequently send the blood uric acid levels. And also another important is that issue of tendon rupture. It's not very common with bempedoic acid. But if you use high intensity statin with bempedoic acid, there is more chance of muscle or tendon issues. So you need to be, suppose the patient is complaining of, if you suspect the severe myalgia or rotator cuff injury or some tendon issues, at least tendonitis. So then you need to think of discontinuing therapy, or you need to observe those therapy. And also the thing is that, and also if the important thing is CRCL is less than 30, because in end-stage renal disease or patients undergoing dialysis, there is no much data of bempedoic acid. So I would recommend using bempedoic acid if the eGFR is more than 30.
Yeah. So thank you so much, sir. Sir, it was indeed a pleasure and honor having you in this event. We, on behalf of Zydus Life Sciences, would like to extend our sincere thanks to you for your comprehensive session. We are sure our delegates would have definitely got enlightened regarding the usage of bempedoic acid, as you have covered all the possible aspects in your session. At the same time, we would like to thank all the delegates for their presence and patient hearing. Thank you all once again, and sir, it's our honor to have you here in this session.
Okay,
Thank
thank
you
you,
all,
Sarang,
and
for
have
your
a great
nice.
evening.
Thank you, Sarang, for your nice words, and I'm really honored to become a speaker of your Clear Talk. So thank you very much for giving me the opportunity, and thank you all for your patience hearing, and very good night. Thank you all again.